So what I thought I'd do today is to just talk a little bit about what we do with the rehabilitation program for erectile dysfunction following prostate cancer surgery. Just a quick disclosure slide. We will be talking about some medications tonight, and I'm on the advisory board for several of these medications that I'll talk about. What do we mean by a bloke who has erectile dysfunction? Well, we mean the inability to achieve or sustain an erection which is satisfactory enough for the man or his partner. Now, penile rehabilitation, what do we mean by that? Well, it's defined as the use of any drug or device at or after prostate cancer treatment to maximise erectile function recovery. And the whole aim of this is to prevent any of these smooth muscle changes, which I'll talk about, that can occur in the penis, so that we actually maximise the chances of a man returning to his normal preoperative function. So that's what we mean. Now, is it important? Do you think it actually matters to a bloke? Many men that I see with prostate cancer, all they're really interested in to start with is, let's get rid of the cancer. It doesn't really matter about all the other things such as the erectile dysfunction. We'll think about that later. But in fact, we actually need to think about it nice and early, because while it may not be important at the time, it is actually important. From the earliest of ages, as soon as a bloke finds his penis, he's actually interested in it. So it is important, and I don't think it matters how old you get, whether you're in your late teenage, early 20s, or even if you're old. This is a nursing home with the lots. Is a little bit to the left, please. Now, erectile dysfunction is common anyway, even if people don't have prostate cancer surgery. Even I can remember these figures. You know, we have 40% at age 40, 50% at age 50, 60% at age 60. So I don't want to live till I'm 100, because if you follow that through, you can see exactly where I'm going to end up. Now, we're not saying that 60% of men are totally impotent at age 60, but 60% do have some degree of difficulties with erections. So even without prostate cancer surgery, it's common. And many men that I see, even before their surgery, already have erectile dysfunction, and we can see why on these figures. It's now estimated, excuse me, it's now estimated that maybe 10% of all patients that we see with erectile dysfunction have the cause of it as a result of some type of radical pelvic surgery. And most typically nowadays that would be a radical prostatectomy. When you look and Google these types of things and different types of specialists, particularly coming out of the States, they will actually quote potency rates anywhere between 30 to 90%. The problem is that we probably know that a lot of this is overestimated with their potency rates, and it's the way that the thing is defined, it's the way they define erectile dysfunction, which may be different to what a bloke depends on what he thinks is his good erectile function. So what can happen with this? The problem is there's inconsistent data. If a bloke gets the tiniest of erections after the surgery and then never gets them again, does that mean that he had erectile function following surgery? So it depends on the way that we define it. It depends on how the patients are selected. If I was advertising my practice, and if I was a urologist and I wanted to say that I get very good potency rates, then I would only operate on very young people who had very good potency rates beforehand, who had very minimal cancer, right? And that would make my figures look good. Luckily in Australia we don't do that, and you don't tend to find that people advertise their potency rates, which is a good thing, and I'll go into that a little bit better. But what I can say to you, and I see patients from all of the different urologists in Queensland anyway, there is no doubt that there are better outcomes with people who are experienced at doing the prostate cancer surgery. There's no doubt about that. So what are some of the things that we do see after surgery? Well, we see erectile dysfunction, as we're going to speak about. And ejaculation. Now, what's that mean? You don't ejaculate. You'd be surprised at the number of men I see having had surgery, and they come in and say, now listen, something's wrong. I orgasm, but nothing comes out. Now, I know that the urologist, excuse me, I know that the urologist would have explained that they've removed the prostate and they've removed the seminal vesicles, so there is no fluid left to ejaculate. But this seems to go past with all the other information that's being given. Some people will get altered sensation when they orgasm. It may be painful. Some people find it more pleasurable, and some find it the same. But there is often some type of change to the orgasm, what we call dysorgasmia. We have penile length alterations, and I'll speak about that in a little while. Why is it that sometimes a penis appears to be shorter after a radical prostatectomy? And this actually matters to a bloke. They don't want to have a shortened penis, you know, and so there are ways of actually maximising that. Curvature. Some people will get an actual bend when they get an erection, so-called Peyronie's disease, and we'll talk about that as well. And then climacturia, which is urine leakage at the time of orgasm. Lots of people get very distressed about this leaking of urine. They're quite happy to ejaculate semen, right, but not urine, okay, even though it's probably both sterile. Okay. So why do people get erection problems after they have a radical prostatectomy, for instance? Well, it can be neurogenic because the nerves get damaged. It can be that the arteries aren't working well, what we call arteriogenic. It can be venogenic, which means that the blood is leaking back out of the penis through the veins. There's always a psychological component, or it could be mixed with all of these things, and we need to tease through this to work out what we're going to do. As Philip will probably go through in his presentation, what a lot of people don't understand is they think there's just a nerve that runs down, the surgeon gets it out of the way, takes out the prostate and the cancer, and then it should just come straight back again if they've spared the nerves. He told me that he spared the nerves. How come I can't get erections? In actual fact, these nerves are almost like a tissue or a cobweb of nerves that are attached on the side of the prostate. And at surgery, these need to be peeled off and lifted out of the way and then take the prostate and the cancer out. And the touching of the nerves, the peeling off of the nerves in order to preserve them causes a temporary damage, and the nerves become stunned and bruised for a while. This can take 12 to 18 months to come back. So it's nothing that happens quickly. It can be 12 to 18 months while these nerves remain what we call neuropraxic. It's similar to if you lie on your arm and you wake up and your arm's dead and you've got to kind of lift it out and wait for the feeling to come back in. That's one of the common neuropraxias that we can get from sleeping, and this is what happens around the penis. And it is now thought that if we don't do some type of rehabilitation, that less than 10% of patients will return to their pre-operative, how they were before the surgery with their erectile function. So this whole idea of rehabilitation has become very important now worldwide. And I'll say why that's important as we go along. But in essence, the whole idea of the rehabilitation is to keep the blood flowing through the penis while we wait for these bruised and stunned nerves to kick back in again. Okay. A male will get 6 to 8 erections every night during rapid eye movement sleep. When we wake up in the morning, if you happen to wake in rapid eye movement sleep, you'll have one of these morning erections that all men are familiar with. A young baby also gets the same 6 to 8 erections while it's sleeping during rapid eye movement sleep. So why do we get that? Why do we get these 6 to 8 erections during rapid eye movement sleep? Well, we now know that this is the way the penis oxygenates itself. This brings fresh oxygen into the actual erectile parts of the penis. And if you were not to get that, and if you were not to get that regular blood flushing through, we start to get this scar tissue developing in the penis, a term that we call fibrosis. And if you get scar tissue, less blood comes in. More scar tissue, less blood, and it gets worse and worse. Now, of course, the nerves are the things that open the arteries up. And if they're stunned and bruised and we're not getting that regular blood flushing through, we start to get the scar tissue developing. So the whole idea of rehabilitation is to work out a way that we can get that fresh blood coming back into the penis to prevent that scar tissue from occurring in the first place. Now, what about the age of blokes when they come in to get their prostate cancer? We're seeing younger and younger men, but we have to remember, though, that a lot of the men that I see even before the surgery already start to have some erectile dysfunction. We spoke about before the 40% at age 40, 50% at age 50, etc. But we also know that people who have high cholesterol, people who have high sugar, people who have a waist circumference bigger than they should around the belly, all these things that can actually cause vascular problems such as heart attacks and strokes also cause erectile dysfunction. And so a man may have many of these risk factors, and then we play with the nerves as well, and therefore they're going to have a lot more difficulty in regaining their function. We also have to remember that most of these men have had a physical reason because the nerves have been peeled back, but there is always a psychological component to this. Is this going to come up this time? Is it going to stay up? Am I going to disappoint myself, my partner, etc.? And what happens is we get the release of adrenaline from our adrenal glands, which constricts the arteries. Adrenaline is a very powerful constrictor of these arteries, and that makes it worse. Now, I do see some men who have just purely psychological reasons why they get erectile dysfunction. These men get good hard erections in the morning, probably good erections by themselves, but not with their partner. Like a patient I saw this morning, Mr. Schwartz, it says, "Mr. Schwartz, the test shows you're not impotent. Your penis is just scared to death." Okay, so this whole idea of rehabilitation, where did this all start from? Probably the first person who did this was an Italian urologist by the name of Francesco Montorsi. And what he did is he got a group of patients and he injected them. He put an injection into their penis 3 times a week of a stuff called prostaglandin, or L-prostadil. And then he had a control group on the side. And they had no type of treatment. We just waited for the nerves to come back. And there was no doubt that the people who had the injections statistically had a better recovery of their erections. And if you look at this, 67% versus 20% erection, good enough for intercourse. So that was with the injections. Then several other studies since that, such as John Mulhall, Haran Padmanathan, have shown that we can do this also with tablets, such as Viagra, Cialis, Levitra. So let's go through this very quickly. We now know that probably 85% of men, originally or soon after they have their radical prostatectomy, don't respond to the tablets. 15% do, but 85% don't respond initially, particularly for the first 6 weeks. Interestingly though, most of them do after around about 2 years, 22 months, and it can be anywhere in between that. So what do I do? What do I do if a bloke comes in and he's going to have his surgery or he's just had it and we now want to get the erections? Do I use tablets? Do I use injections? What do we do? Well, to date, there is actually no formal analysis of how we do this. We actually don't have a protocol that everyone follows. The one that's most widely used is the one by John Mulhall from the Memorial Sloan Kettering. And this is a complicated slide. But if you look at it, we try and see the patients before they have their surgery. I explain what's going to happen to them, why the most important thing is to get rid of the cancer, but your 2 main side effects that you're going to get are the urinary incontinence and the erectile dysfunction. And in 2013, it's no longer good enough for us to say, well, get your prostate cancer out, but you'll wear an incontinence pad from now on and you won't get erections anymore. But that's just the way it is. At least we saved your life and got rid of your prostate cancer. That's not good enough in 2013. We want 3 outcomes. We want the trifecta. No cancer, normal erections and normal continence. But the only way that you're going to get these other 2 things are if we do some type of rehabilitation program. The pelvic floor exercises for the incontinent, etc., and the getting of the blood through the penis to stop it scarring. So we see them, we explain all this. The idea is that what we want them to do is to maximise their erections before the surgery. If they already have erectile dysfunction, and many of the patients I see do, then I will start them off on some type of treatment before surgery so that I can get as much blood into the penis beforehand, so we're starting from the highest possible point. Then what happens is they go into surgery and they have a catheter in. The catheter is in for a week and it comes out, unless there's some complications, but it comes out after a week. I then want to see them a month after the catheter comes out, and I want them to try each one of the tablets. What in essence I want to know is, are they a tablet responder or not? If they respond to the tablets and they get a good erection, then we'll go down that pathway. If they don't, I move immediately over to the injections. Sorry, I've got that around the wrong way. I'm looking the wrong way. This is the non-responder. We go right to the injections and then we keep going back and trying the tablets. Because you know what? It doesn't matter how we get the blood into the penis, just as long as we do, so we're bringing that fresh oxygenated blood in order to prevent it from scarring. So in essence what we're after is, are you a tablet responder or not? As I said to you before, don't be surprised if initially the tablets don't work. And we do find that up to 85% of men do not respond initially. I want a bloke to get 2 to 3 erections per week until the nerves recover. That's what we want, 2 to 3 erections a week. It doesn't mean you have to have sex, and if I've got the partner beside me, I say to them, it doesn't mean you have to have sex with him 2 to 3 times a week if you don't want to, but I want you to have 2 to 3 erections a week to keep the blood flowing through. And that's what's going to stop it from scarring up. We may start on the tablets, we may go to the injections, and we may swap back and forward, and what will happen is it's important that we see the men every couple of months and adjust and refine our treatment. But the underlying principles of treatment are 2 to 3 good erections a week until the nerves come back. Okay, so to summarise that very quickly, optimise the erections for 2 weeks before surgery. Commence the tablets from the day the catheter comes out or as soon there as possible. I review them at 4 to 6 weeks after the catheter comes out and I decide are they a tablet responder or not. If they are not, we go to the injections and we periodically re-challenge with the tablets. Now, what else should I do though? If a bloke's got erectile dysfunction as a result of the prostate cancer surgery, what about all the other things? We have high blood pressure, high cholesterol, high sugar, smoking, increased abdominal circumference. All of these things contribute to a bloke having erectile dysfunction. And it's important that we address all those because that's going to maximise our chance of recovery. More and more of the patients that I see these days are like this. Right? Now, a bloke who has central obesity, increased waist circumference, diabetes, high blood pressure and high cholesterol, if a bloke's got all 4 of those, the so-called metabolic syndrome or the awesome foursome or the deadly quartet, what are they at increased risk of having? A heart attack or stroke. But what else are they at increased risk of having? Erectile dysfunction. And in fact, the erectile dysfunction occurs before they have a heart attack or stroke because the arteries are smaller, right? And they're the ones that get affected first. So it's all very well for me to be treating them with tablets and doing all that, and yet if in the background they've got these other things that are actually contributing to their erectile dysfunction, well, we're wasting our time. So we need to be holistic about this and treat all of it. So in essence, if a person has a post-radical prostatectomy erectile dysfunction, do I treat them differently than I treat any man who has erectile dysfunction? And the answer is no. We treat them the same. You correct all the risk factors, get them to get rid of the gut, get them to get rid of the smokes. Look, they've been told for years, you may get a heart attack, you may get lung cancer, and they keep smoking. Your penis may not work. Oh, I better get rid of them then, you know. It's often a very powerful reason for blokes to stop smoking and to get rid of these risk factors. We start them off on the tablets. If the tablets don't work, we go with the injections. If the injections start to work and the morning erections, we go back to the tablets. If none of these work, or if the patient's looking for a permanent solution to their erectile dysfunction, then we have the implants and the surgery, which Philip Catalaris will talk about. What about a vacuum device? What do I think about vacuum devices for the recovery after a radical prostatectomy? Well, I don't think it's probably as important. It will certainly give an erection, but what the vacuum devices do is they bring old venous blood from the veins back into the penis predominantly. And what I'm after for a rehabilitation is the fresh oxygenated blood through the arteries. Having said that though, they do produce an erection. The way they work is this: we have a cylinder which goes over the penis and it has a little pump that sits either on the base of it or held in the hand. And what the bloke does is he operates this pump. It creates a vacuum in the chamber and the blood gets sucked back into the penis and he'll get an erection. There is a little rubber band which sits around the base of this tube. It gets lifted off onto the penis to trap the blood in there. But rather than being red and warm, this erection is blue and cold, right? And from here down is erect, but from here back is not. And so if that thing is halfway down the shaft, for instance, you'll get this hinge effect or this whirlybird phenomenon, you know. And if you're trying to have sex with something that's waving around like that, right, it'll bounce on the side, buckle, tear and all the rest of it. I'm not a big fan of the vacuum devices, right? But if you don't mind a blue cold penis that's quite unstable, it's for you. All right? What about the injections? Do you know, I've never had a bloke sit in my office and say, can I put an injection into my penis, please? Never, right? And yet we have thousands of men currently on the injections. They are very good treatment. We use a diabetic syringe, like the children with the diabetes inject their insulin, or like an EpiPen, or like the Clexane if you have to inject yourself after surgery or after being on a plane flight to stop clotting. That's the colour of the needle we're talking about. And if it's done correctly, it is actually quite painless. So, the side effects of this is mainly due to technique. We always used to say scarring was one of the side effects of the injections, but in fact, when you look at the evidence of this, there's very little evidence to show that the injections themselves can cause scarring. In fact, not getting the blood into the penis is the main thing that causes a scarring by not getting it oxygenated. And if you do this correctly and you go from side to side, as we instruct the men very carefully to do, then the incidence of scarring is probably not that high. Priapism it's a prolonged erection, and this is probably the true emergency of the injections. If you give yourself too much, you may get one of these erections that hang around and don't go down. And we don't want that. It is a medical emergency and it can cause damage to the penis. So we've got to be very careful. Bruising, if you hit a blood vessel, the penis may bruise on the surface. And the other thing is pain. We find that a large percentage of men will get pain from a particular stuff, the prostaglandin mixture that we put into there. And if that's the case, that doesn't mean we don't use the injections. We can just use other mixes. But all I really want, as I've said, is to make sure the blood keeps coming through the penis. If I've got a bloke on injections, I follow them up carefully so that they're doing it properly. And if instructed and if they're doing it properly, it's very safe and it's very effective. So for those of you who are on injections, and some of you will be in the room, what's the trick to doing it to make it painless and so that it works? Well, firstly, it's got to go in the right spot. What I tell people is, imagine this is a clock face. That would be 12 o'clock, 3 o'clock, 9 o'clock. When you inject, we want you to come in at either the 10 o'clock or the 2 o'clock angle, at right angles to the shaft of the penis. The needle's not aiming back towards you, it's not aiming away, directly in at either the 10 o'clock or 2 o'clock angle. And the secret is you must pull the head of the penis forward firmly. So you grasp it by the head of the penis and you stretch it forward as hard as you can. The needle goes in a lot easier that way. If you've got a foreskin, you pull the foreskin back, grab it by the head and pull it forward. If you're feeling it hurt when you put the needle in, you pull it forward a bit harder, right? And you have control over any discomfort you feel. That is the trick to injecting and making it not hurt. What we don't want is a priapism, these prolonged erections. And that's probably the only real side effect of the injections. So what do we define as a priapism? Well, a prolonged erection that's actually not associated with sexual stimulation. And it is possible that after 24 hours that may become permanent. Now, I get blokes in my room saying, oh, that sounds like a great thing, you know, that wouldn't worry me. That would worry you. It's painful, it's sore, and it can be dangerous. So we do not want it, and we start low and work up. But we need to have an action plan. So what's the action plan? If the erection's up for 2 hours, I want them to take 2 60 milligram Sudafed tablets. Now, instantly this creates problems. They go into the chemist with this erection that won't go down. They ask for Sudafed. The pharmacist thinks they're running a meth lab and won't sell it to them, so they've got to try and convince them that they're having it for real reasons. So I write them all a letter, and they can give it to the pharmacist discreetly and get their pseudoephedrine. If another 2 hours goes by, it's now been up for 4 hours, they take 2 more. And if it's been up for 5 hours, then they need to go to the accident emergency department. They don't want to go to the accident emergency department. They think they'll be lying in cubicle 3 and all the nurses will be saying, have a look at the bloke in cubicle 3 with a big erection. And that's exactly what would happen, all right? So they stay at home with this thing, and that's when they... I'd go in and have a look myself if one came in. But see, the thing is that they don't want to do it. They stay at home, and this is where they run into trouble. It does not normally happen with the tablets, right? With the tablets, you need to be aroused. So the shows that you see on TV where a bloke takes one of the tablets like Viagra and gets this erection that won't go down, that's nonsense. It's the injections that cause it, not the tablets, unless you've got some rare type of priapism-inducing condition such as sickle cell anemia or one of the leukemias. I won't talk about the implants because Philip's going to do that, but it's an extremely good treatment and it's a permanent. But the main thing that most blokes want to get on, of course, is the tablets. And the first one that came out was Viagra, right? Now, Viagra was originally meant to be an anti-anginal agent. It was for blokes who had angina. Now, it didn't work, but they wouldn't give their tablets back because all of a sudden they could get erections again. Now, why did these blokes who were in a cardiovascular thing with heart conditions, why did they find that it worked? Because they all had erectile dysfunction. They had erectile dysfunction because it's the same risk factors that cause their heart problem that cause the erectile dysfunction. And of course, once the company found out what this could certainly make a lot more money, worked out what it could do, they marketed it, you know. It came out in America at the same time that Titanic did. And what happened is all the ladies were lined up to get their Titanic tickets, you know, and the blokes lined up outside the pharmacies. Now, while this was published in one of the magazines, that's actually what happened. They sold out. People were actually trying to get these in from the pharmacy because remember, up until the tablets, all we had was injections, vacuum devices and surgery. The real problem is, though, that when all this came out, not long after came all the snake oil salesmen. And you will get the same ads that I do. You will see the same billboards that I do, right, of all these different types of things that are going on where they take your credit card, take as much money out of your credit card as possible, right, for things that are completely unproven and untrue. If you have any type of troubles with erections, please go and see your GP. Don't answer advertisements and billboards and things like that, right? Or you will be parting with money, lots of it. So how do these tablets work? I'm not giving you a biochemistry lesson here, but I just wanted to point out the whole mechanism of getting an erection is quite complex. And where the tablets work is down here. They inhibit a particular substrate. But you have to have an intact nerve system. And sometimes when these nerves are bruised, these tablets don't work initially. In fact, 85% of men, they don't respond within the first 4 to 6 weeks. So you need to have an intact nerve system, and what's the next thing you need to do? You need to be aroused, right? I get blokes come in and say, tried the tablet, didn't work. So what did you do? Well, I took it and I sat there and I waited and nothing came up, right? It doesn't work like that. You need to take the tablet and you need to take it at least 90 minutes before trying to get an erection. Let it get in the system, at least 90 minutes. So if you took it at 5 o'clock, any time from 6:30 through till probably midnight, right? Even though it says 4 to 6 hours, it works a lot longer than that in the penis itself, but you've got to give it time to get in the system and you need to be aroused. If you're not aroused, you won't get an erection with these things. They do not make it artificially pop up. People are always worried about these, thinking they're going to kill them, right? Oh, I don't want to take that. I've heard it gives you heart attacks and strokes and things. It doesn't, right? This is my death by Viagra slide. And the reason I put that up there was to remind everyone that these tablets do not cause heart attacks or strokes. If anything, they're protective. Remember what they were made for originally? Angina. They open the arteries. So what was all this bit about people dying when they took it? If you are on a medication group called nitrates, these are the things you spray under your tongue if you get angina, or a patch that you wear, or a long-acting tablet like Imdur. You must not take the tablets if you're on those, because those tablets dilate the arteries, so do the Viagra, Cialis and Levitra, but together they can dramatically dilate everything up and drop your blood pressure catastrophically, and people have died from that. So if you are on nitrates, you don't take the tablets, right? It's as simple as that. Even if you carry it around in your pocket and just use it infrequently, I do not give people these tablets because I don't trust a bloke to get an angina attack and say, geez, when did I take that last tablet? I should be right, and spray it under your tongue. You can die from it, right? So we don't use it in those people, but they themselves do not cause heart attacks or strokes. So as we said with the tablets, they need sexual stimulation. You need to have an intact nerve pathway, right? And that sometimes takes a bit of time to come back after a radical prostatectomy. What's the difference between them? People say to me, you've been doing this for a long time. Which tablet do you reckon is best? And I have been doing it for a long time. But I still can't pick a bloke who walks in and say, you know what, you look like a Viagra man to me. And the next bloke comes in and says, I reckon you're a Levitra boy, right? I can't pick it. And if there was one tablet that worked better than any of the others, that's the one I'd use. But I can't pick it. So what I do is I give blokes all three of them. They take them away and try them with their partners, and they come back and tell me which works best for them and what's better for them. We've got daily dosing, we've got on-demand, we've got all sorts of tablets, and we try them. What's the real difference is one of them has a longer half-life called Cialis. So it lasts in the system for 36 hours. It gives you a bigger window of opportunity to have sex. So the bloke says to me, well, that's good, I can have sex tonight and tomorrow night and the next night. They can't, because their partner won't let them. They'll have sex once. And that'll be when their partner says they can. But the bottom line is, if it works, it does give you a bigger window of opportunity. But if it doesn't give us firm an erection, I'd use one of the other ones, right? We want 2 to 3 good erections a week. And what we try and do is to see which is best for the man or his partner. It is important to persist with this. 12 to 18 months is a long time, right? And I'll get blokes who are all enthusiastic to start with. I see them at 9 months and they say, oh, look, I haven't been bothered, or, you know, this happened, I'm back at work, and, you know. You've got to think of this as writing yourself up a gym program for your penis, right? We want 2 to 3 erections a week, no matter how we do it, and if something's not working, go back and see your doctor and get something else. 2 to 3 erections a week till the nerves come back. Because if you don't, and if it scars up, then it may not work anymore. And we do not want this to be the definition of retirement. My nookie days are over. My pilot light is out. What used to be my sex appeal is now my water spout. Time was from its own accord, from my trousers it would spring. But now I have a full-time job to find the blasted thing. It used to be embarrassing the way it would behave. For every single morning it would stand and watch me shave. But as old age approaches, it sure gives me the blues to see it hang its withered head and watch me tie my shoes.
Okay.